Hi everybody, and welcome to our module on male reproductive hormones. By way of review, the male reproductive system begins in the hypothalamus, which secretes GnRH, which stimulates the pituitary gland to release LH and FSH. The LH and FSH hormones stimulate two important cell types in the testes, the Leydig cells and the Sertoli cells. The Sertoli cells are important for spermatogenesis, and the Leydig cells are important for synthesis of testosterone, which feeds back negatively on the pituitary gland and the hypothalamus. And in this module, we're going to talk about how this whole system works to lead to normal male development and normal spermatogenesis. We'll begin with the Leydig cell, which is the main hormone-producing cell in the male. Leydig cells can pull cholesterol from the plasma and convert it into either dehydroepiandrosterone, or DHEA, or androstenedione, both of which are weak androgens. Either of these weak androgens can be converted into the more potent androgen testosterone, which is the major circulating androgen in the male. Now, I just want to point out here that in males, the major source of androgens is the testes. However, androgens also come from the adrenal cortex. DHEA, androstenedione, and testosterone can all be produced in the adrenal cortex, and especially in females, this is a very important source of androgens for the human body. There is another androgen called dihydrotestosterone, or DHT, which is synthesized largely in the periphery. Testosterone coming from the Leydig cells enters the circulation and is converted to DHT in peripheral tissues using an enzyme called 5-alpha reductase. If you look at the bottom of the screen here, the structure of testosterone is shown on the left. The structure of dihydrotestosterone is shown on the right. What 5-alpha reductase does is add two hydrogens to eliminate this double bond, hence the structure becomes dihydrotestosterone. And many testosterone effects are mediated by DHT. DHT has a higher potency for androgen receptors than testosterone. It binds the androgen receptor more strongly than testosterone. It also forms a more stable structure than testosterone. There is a drug called finasteride which inhibits the enzyme 5-alpha reductase. This will decrease the conversion of testosterone to DHT, and this is used in the treatment of prostatic hyperplasia, which I talk about in the prostate video in the reproductive section. But benign prostatic hyperplasia is driven by DHT, so if you inhibit 5-alpha reductase, you limit the amount of prostatic hyperplasia. This drug is also used in the treatment of hair loss in men, and we'll talk about that later in this video. Testosterone can also be converted to estradiol. This occurs in adipose tissue and also in Leydig cells. The enzyme that carries out this conversion is called aromatase. If you look at the bottom left side of the screen, again is shown the structure of testosterone. What aromatase does is remove this carbon here and create three double bonds in this ring here. That creates the structure of estradiol, which is an estrogen, and this is important because some of testosterone's effects are mediated by conversion to estradiol. Shown on this slide is a summary of what I've been discussing on the last few slides. The Leydig cells produce testosterone, and some testosterone effects are mediated by testosterone itself. Other effects are mediated by conversion to DHT, and still other effects are mediated by conversion to estradiol. So in the next few slides, we'll talk about what testosterone does, and I'll point out whether the effects are mediated by testosterone, DHT, or estradiol. So the effects of testosterone in males are different depending on the growth stage. There are certain effects that are important in the fetal stage, other effects are important at puberty, and then finally there are effects that testosterone has in the adult. So we'll talk about each of these stages in the next few slides. Testosterone is very important in the fetus for normal development of the male genitalia, and in order to understand this, we need to review how males develop in general. So the first thing you should know is that the development of the testes requires a functioning Y chromosome. The Y chromosome contains a gene called the SRY gene, which produces testis determining factor, and this drives growth of the testes. So all males who are XY, assuming their Y chromosome is functioning, will be born with testes, and the Y chromosome is what determines their chromosomal sex. You are either XX, female, or XY based on your chromosomes. The growth of your internal and external genitalia, however, requires hormones, so it's possible for you to have a Y chromosome and testes, but to not have normal male genitalia. In order for the normal male genitalia to occur, your hormones, including testosterone, have to develop normally. So you can divide up the male genitalia into the internal and external genitalia. The internal genitalia are things like the seminal vesicles, the epididymis, the vas deferens, and all of these are derived from an embryonic structure called the mesonephric ducts, and all of these depend on testosterone for normal development. The external genitalia are things like the penis and the scrotum, also the prostate and parts of the bladder. These are all derived from an embryologic structure called the urogenital sinus, and development of these structures requires normal levels of DHT. On this slide, I've summarized the role that testosterone plays in development of male sexual characteristics in the fetus, and this will be important in the next few slides when we talk about abnormalities of sexual development in the male. So everything begins with the Y chromosome, which contains the SRY gene. That leads to development of the testes, which includes the Sertoli cells, which produce sperm. We'll talk more about that in a little bit, and also the Leydig cells, which make testosterone. Testosterone goes and triggers the mesonephric ducts to develop into the internal male genitalia. Testosterone is also converted into DHT, and this leads to normal development of the external male genitalia. So now that we understand that, let's talk about what would happen if a baby were born with a 5-alpha reductase deficiency. This is a rare autosomal recessive disorder of sexual development where a 46XY male is able to make testosterone but cannot make DHT, because recall that the 5-alpha reductase enzyme converts testosterone into dihydrotestosterone. When this happens, there are normal male internal genitalia. That's because the Y chromosome is normal and it produces the testes, including the Leydig cells, and the Leydig cells make testosterone. And testosterone drives normal formation of the epididymis, the vas deferens, and the seminal vesicles. The external genitalia, however, remain female. They do not develop into male genitalia. That's because there is an absence of dihydrotestosterone. Therefore, there are absent external male genitalia. There are a range of female genitalia that can be seen. Sometimes there is a hypospadias, which looks like a small penis. Sometimes this is diagnosed at birth due to the presence of ambiguous genitalia. However, other times the baby appears to be female because it's not recognized at birth that internally there are normal male structures. So the typical case of 5-alpha reductase deficiency that you should be prepared to recognize for your board exams is either a male who is born with ambiguous external genitalia, or it may be a female child who is raised as a female and then develops masculinization at puberty. This is a common presentation because sometimes the baby appears to be female, and it's not until puberty, when the Leydig cells produce lots of testosterone, that it becomes obvious that something is wrong. In either case, there will be a blind vagina and absence of the uterus. There are bilateral undescended testes, and on serum testing there are normal testosterone levels, and this is the tip-off they're probably going to tell you in a board question to help you recognize that it's a 5-alpha reductase deficiency and lack of dihydrotestosterone. And if we go back to this overview here, the problem in a 5-alpha reductase deficiency lies at this step. So the external genitalia do not form normally and DHT is not synthesized. Testosterone levels, however, are entirely normal, so that the internal genitalia are normal. The Leydig cells, testes, and Sertoli cells are also entirely normal. Now let's talk about the effects of testosterone at puberty. To help remind you of these effects, I've shown you a picture of a person on the screen at about the age of the onset of puberty. In case you're wondering, this is not a picture of me as a teenager. I did not wear glasses. So the effects of testosterone at puberty include many of the things we associate with the male phenotype. There's enlargement of the scrotum and the testes, increased penis size, enlargement of the seminal vesicles and prostate, growth of pubic hair, also hair on the face and underarms, and also deepening of the voice. Testosterone is also important at puberty for the growth spurt, but you should be aware that this effect has been well described to be due to conversion of testosterone into estrogens. In males who lack the estrogen receptor or males who cannot synthesize estrogens, the growth spurt does not occur normally. So via this mechanism, testosterone and estrogens lead to increased linear growth. This is why boys grow taller at puberty. In addition, it will ultimately lead to closure of the epiphyseal plates in the bones. Androgens are also responsible for the acne seen at puberty. Acne is associated with several factors, but one of them is increased sebum. Sebum is the secretion of the sebaceous glands found in the face, and you should know that these sebaceous glands have lots of androgen receptors, so androgen can stimulate growth and secretions coming from these glands. For this reason, acne is common in puberty, and it's also common in other conditions where there is an excess of androgens. For example, among women with the polycystic ovarian syndrome and among children born with some of the congenital adrenal hyperplasias where they secrete excess androgens from the adrenal gland. So what are some of the effects of testosterone in adults? Well, first of all, testosterone and androgens in general can drive prostate growth. And we mentioned earlier how the drug finasteride decreases the production of DHT from testosterone, and that's used as a treatment of BPH, or benign prostatic hyperplasia. And I talk about this in the reproductive video on the prostate gland. In addition, men who take testosterone therapy for any reason often develop BPH as a consequence of therapy. There are a number of effects of testosterone on lipids. Exogenous testosterone will lower the good cholesterol HDL and raise the bad cholesterol LDL. And then finally, testosterone is responsible for male pattern balding, so let's talk about that now. Androgenic alopecia is the formal name for male pattern balding. This is the most common type of hair loss in men. Men can lose hair in the anterior scalp, the mid-scalp, the temporal scalp, and the vertex, which is the top of the head. If you look at this picture on the screen, this man has thinning of the hair at the top of the head. In addition, this area right here often has hair loss in androgenic alopecia. Interestingly, the sides and the back of the head typically do not have hair loss in this condition. If you see men that have hair loss there, that's usually for some other cause. It's often seen in people who are undergoing chemotherapy. This pattern of balding is caused by androgens. It occurs after puberty, and it will not occur in men who have an androgen deficiency. It requires androgens. And DHT is the key androgen, and we know this because this type of balding responds to finasteride treatment. So finasteride lowers the levels of DHT, and it minimizes the hair loss in this condition. Now that we understand the effects of testosterone, let's talk about what happens when men have low testosterone levels. This is called hypogonadism. There are many congenital and acquired causes of hypogonadism. One of the ones that you will most commonly encounter clinically is the fall in testosterone level that occurs with aging. As men age, there is a fall in the serum testosterone level. There's also a rise in the amount of sex hormone binding globulin in the plasma, and this lowers the amount of testosterone that is freely available to exert its effects on tissues. The fall in testosterone level may be associated with a drop in sexual function. It may be associated with a fall in bone mass. And then importantly, it may lead to anemia. I've bolded the word anemia because you should be aware that low testosterone can cause anemia. In addition, exogenous testosterone that men may take as therapy can cause an elevated hematocrit. We'll talk more about that in a minute. One thing you should know about the hypogonadism that occurs with aging is that there are limited data on hormone replacement for decreased testosterone due to aging. This is a controversial topic. Many men seek out and request hormone replacement for low testosterone levels, but it's not clear that it has a definite benefit. So now let's talk about testosterone therapy. Exogenous testosterone is available and can be used as a treatment for male hypogonadism. It will result in increased muscle mass in adults and also increased bone density. It has some potential adverse effects. First of all, it can raise the hematocrit. This is a normal response to testosterone therapy. And then also it can cause all the things that we have talked about testosterone causing. This includes acne, balding, and worsening of prostatic hypertrophy. Another adverse event that happens among men who take testosterone therapy is that there is a fall in their sperm count. Spermatogenesis is suppressed by exogenous testosterone. The mechanism of this effect is that testosterone suppresses LH secretion from the pituitary. This leads to low testosterone production from the Leydig cells. Now you might think that the exogenous testosterone could replace the testosterone coming from the Leydig cells, but that's not how it works. Exogenous testosterone has a weak effect in the testes. It is not the same as the testosterone that comes from the Leydig cells, and thus there is a fall in the sperm count. You may have heard of bodybuilders who take anabolic steroids. Anabolic steroids are high dosages of androgens. They're taken by bodybuilders to increase muscle mass. Sometimes they take exogenous testosterone, other times they take androgen precursors, but they all lead to increased testosterone effects, and one of those effects is to increase the muscle mass. They also have various adverse effects, all related to testosterone, so they will negatively impact the serum lipids. The HDL or good cholesterol will fall, and the LDL or bad cholesterol will rise. There will be an increase in the red blood cell count and erythrocytosis. The testes will become small. This is from suppression of FSH and LH coming from the pituitary. There will be a low sperm count, which is called azoospermia. And then finally, men who take anabolic steroids can develop gynecomastia. This is because the testosterone is converted to estradiol by aromatase, and this will lead to gynecomastia. This is a picture of a man with gynecomastia shown on the screen here. There's a tie-in here with pharmacology, and that has to do with the drug spironolactone. Spironolactone is a potassium-sparing diuretic. You can see from its structure shown on the screen that it is similar to many steroid hormones, and for this reason it blocks the effects of aldosterone on the kidneys. This makes it useful in hypertension and also heart failure. A key side effect of this drug is that about 10% of men who take spironolactone develop gynecomastia or breast enlargement. This is because it blocks the androgen receptor. It also decreases androgen production from androstenedione. It blunts the conversion of androstenedione into testosterone in the testes. For both of these reasons, men who take this drug see a rise in estrogen effects and a fall in androgen effects, and this can lead to gynecomastia as shown on the screen here. Now, in men, spironolactone can cause gynecomastia, but in women, the drug can actually be used as a treatment for acne, hirsutism, or alopecia. These symptoms are often caused by androgen excess, so using spironolactone as a drug therapy will blunt testosterone effects and enhance estrogen effects, and that can potentially resolve these symptoms in women. Now, one other word on the effects of spironolactone in women: this drug can cause amenorrhea in women who are still menstruating. That's because it is actually a derivative of progesterone. Spironolactone is made from progesterone, and in addition to blocking androgen receptors, it also stimulates progesterone receptors. So when progesterone receptors are stimulated, that leads to amenorrhea. It's analogous to what happens in pregnancy, and the woman will not menstruate. So in women, the effects are different than in men for spironolactone, but an easy way to remember all of them is to just know that spironolactone blocks androgen receptors and activates progesterone receptors. And a final word on spironolactone: there is a drug called eplerenone which has a slightly modified structure to spironolactone. It still blocks aldosterone effects, but it does not cause gynecomastia. So this is an alternative drug that will not cause gynecomastia, and it can be used in heart failure among men who develop breast enlargement while taking spironolactone. So now that we've talked about the Leydig cells and the effects of testosterone, let's talk about the other cell type found in the testes, and those are the Sertoli cells. And these cells are important for supporting and nourishing developing spermatozoa. They regulate spermatogenesis. If you look at this picture on the screen, the way that sperm develops is that they begin as a spermatogonium, which goes through a series of developmental stages until they develop into spermatozoa, or sperm. This all occurs in the seminiferous tubules, and this is a cross-section through a seminiferous tubule shown on the screen here. The lumen is in the middle. Along the sides here are sperm in various stages of development, and around the periphery are Sertoli cells, like one that is shown right here, which will support the sperm cells through spermatogenesis. Sertoli cells are stimulated by FSH coming from the pituitary, and they are supported by the Leydig cells, which secrete testosterone and release it onto the Sertoli cells in a paracrine fashion. So the important point here is to recognize that you need both FSH and LH for normal spermatogenesis. In that picture I showed you before, we saw a seminiferous tubule with Sertoli cells around the periphery, and they form a tight barrier to isolate the sperm cells. This is called the blood-testis barrier. The tight junctions between adjacent Sertoli cells form this barrier. It isolates the sperm, and it protects them from autoimmune attack from the body. The Sertoli cells secrete an important substance called inhibin B, which exerts negative feedback on the pituitary gland to inhibit FSH. Like I told you before, the pituitary releases FSH, which stimulates the Sertoli cells. The Sertoli cells in turn secrete inhibin, which feeds back on the pituitary. Basically, the inhibin tells the pituitary that the Sertoli cells are receiving the FSH signal so that FSH levels fall. If the pituitary gland does not receive inhibin, the level of FSH will climb as the pituitary tries to stimulate the Sertoli cells more. Sertoli cells secrete a protein called androgen-binding protein that raises and maintains local testosterone levels in the testes. Because of androgen-binding protein, the intratesticular testosterone concentration can be 100 times higher that of the periphery, and this is part of the reason why exogenous testosterone leads to a fall in the sperm count. Exogenous testosterone can never replace the testosterone that naturally occurs in the testes when the Leydig cells synthesize the hormone and it binds to androgen-binding protein. Sertoli cells also produce a hormone called anti-Müllerian hormone. This is important in male development in the fetus because it results in degeneration of the Müllerian ducts and the female structures. So let's talk about anti-Müllerian hormone in a little more detail. In utero, very early on in development, whether the baby is XX or XY, there are initially two reproductive systems present. First of all, there is an indifferent gonad, which can potentially develop into either ovaries or testes. There is also a female structure called the paramesonephric or Müllerian duct, and a male structure called the mesonephric or Wolffian duct. If the baby has a Y chromosome, this will lead to the development of testes, and the testes include Sertoli cells. Those Sertoli cells will secrete anti-Müllerian hormone, which is also sometimes called Müllerian inhibitory hormone or Müllerian inhibitory substance. This hormone leads to the degeneration of the female or Müllerian system. It leaves behind the gonad, which becomes the testes, and the mesonephric ducts. Now that we understand that, we can go back to this slide and add the fact that the Sertoli cells secrete Müllerian inhibitory hormone, and this leads to the degeneration of the female or Müllerian structures. And this is why boys aren't born with a uterus and fallopian tubes. Even though they initially in utero have a Müllerian duct, it goes away because of the Sertoli cells and the secretion of Müllerian inhibitory hormone. Now we have all the pieces in place to understand a rare disorder that they like to ask you about on your boards to test your understanding of male sexual development. This disorder is called the complete androgen insensitivity syndrome. In this disorder, male babies with an X and a Y chromosome are born appearing to be female. This disorder is caused by mutations of the androgen receptor. It occurs in males with an X and a Y chromosome. These babies are born with no ovaries. That's because they do have a Y chromosome. Therefore, the testes form in utero. They have a functioning SRY gene. The problem problem results because there is no cellular response to androgens, and for this reason there is no internal or external male genital development. In addition, the Sertoli cells in the testes are present and they are secreting Mullerian inhibitory hormone. This leads to degeneration of the Mullerian structures. So even though these babies are born appearing to be female, they will have an absent uterus and fallopian tubes. If we go back to this slide, in the androgen insensitivity syndrome, the problem is that testosterone cannot exert its effects. For this reason, the baby does not form the male external or internal genitalia, and it will appear to be female at birth. The Sertoli cells are, however, present, and they secrete Mullerian inhibitory hormone, and this leads to degeneration of the Mullerian structures, and therefore the baby is born without a uterus or fallopian tubes. This disorder is sometimes diagnosed at puberty when a child who appears to be a girl develops breasts but does not develop armpit or pubic hair. The breasts develop because testosterone can be converted into estrogen. However, the armpit and pubic hair depends on the effects of androgens, which are not present. In addition, there is amenorrhea. That's because the child does not have a uterus, and there are also usually abdominal testes. Another way this disorder is sometimes diagnosed is in a child who appears to be a girl who develops an inguinal mass, and when that mass is biopsied, it's determined that the mass is testes, and those are undescended because the child has the androgen insensitivity syndrome. This slide shows an algorithm so you can better understand disorders of sexual development. So if a baby is born with ambiguous genitalia or a child develops abnormally at puberty, the first test you want to do is a karyotype to determine whether the child is XX or XY. The next test you want to do is to look for the presence of Mullerian structures. Basically, you want to see if there is a uterus or fallopian tubes. If the Mullerian structures are present, it means that there is an absence of functioning testes, because if the testes are present and they are working, then the Mullerian structures will degenerate. So let's consider the case of an XX female who does have Mullerian structures present. This is often due to congenital adrenal hyperplasia. In several of the adrenal hyperplasias, there is an excess of androgens produced from the adrenal gland, and this can lead to development of ambiguous genitalia or abnormal puberty in a child who has two X chromosomes. In the case of a child with an X and a Y chromosome, if the Mullerian structures are present, that means there's some problem with the gonads. They did not develop normally, and there was no secretion of Mullerian inhibitory hormone. If there is an absence of the Mullerian structures in a child who is XY, then the problem is lack of androgens in some form. This could be due to some of the more rare congenital adrenal hyperplasias. In some of those syndromes, there is a lack of androgens. It also could be due to androgen insensitivity, or finally, it could be due to low levels of dihydrotestosterone. But whatever the reason, there is a lack of androgen effects if you have an XY child who has an absence of Mullerian structures. It means the testes are working, but there's a lack of androgens, and therefore the child is not developing normally. I'm going to finish this module by talking about temperature effects on the testes. There's a reason that the testes are in the scrotum and not in the abdomen, and that's because spermatogenesis is more effective when the temperature is reduced. You can imagine how this developed evolutionarily. Males who had their testes in the scrotum were more effective at spermatogenesis and hence were able to reproduce more effectively. It turns out that the Sertoli cells and Leydig cells do not respond the same to changes in temperature. The Sertoli cells are very sensitive to temperature. When the temperature rises, there's less spermatogenesis. They also release less inhibin, and this leads to a higher FSH level. The Leydig cells, on the other hand, are less sensitive to temperature, and for this reason, testosterone production is usually maintained even at higher temperatures. This is important in the disorder called cryptorchidism, which literally means hidden testes. This is usually due to undescended testes that remain in the abdomen or stay in the inguinal canal and do not travel all the way into the scrotum. And it can be unilateral or bilateral. In either case, the testes will be exposed to higher than normal temperatures. Now that you understand that, you can understand some of the complications of cryptorchidism. So undescended testes lead to low sperm counts. That's because of the effect of higher temperature on the Sertoli cells. In addition, there will be low inhibin levels, and I've bolded this because this is the type of thing they like to ask you on step 1. Undescended testes carry an increased risk of development into germ cell tumors, and for this reason they need to be corrected or removed. In addition, children with cryptorchidism often have inguinal hernias. That's because the testes do not descend normally through the inguinal canal. And then finally, a risk of undescended testes is the development of testicular torsion. This is when the testicle rotates and twists the spermatic cord. This leads to compression of the veins and it drops the blood flow, and this can lead to hemorrhagic infarction of the testes, and this is a very dangerous condition. This condition is often diagnosed in children when the scrotum is examined and one or both of the testes are missing. This condition can initially be observed. The testes may descend on their own. They usually do this by 6 months of age. The surgical procedure to correct cryptorchidism is called an orchiopexy. It's surgical placement of the testes in the scrotum. When this is done, the sperm counts usually become normal, and this is usually done after 6 months of age if the testes don't descend on their own. A special note on bilateral undescended testes. This occurs when a baby that appears to be a male has bilateral non-palpable testes. The dangerous cause that you must consider in this situation is that the baby may not be a male, but may in fact be a female. This can happen in some of the congenital adrenal hyperplasias. In some of these disorders, females with two X chromosomes are exposed to increased androgens. This can lead to the development of ambiguous genitalia, and thus the baby may appear to be male with absent testes when in fact it is a female. This is a dangerous situation because there's a risk of shock from low cortisol. So important tests to do here are an ACTH level and a cortisol level. Another potential cause of bilateral undescended testes is that the testes may be absent altogether. This can occur if they don't develop normally or if they atrophy. This sometimes happens if there's intrauterine vascular compromise. To make this diagnosis, serum testing is often done. Because the testes are absent, you will see high levels of LH and FSH, and there is an absence of Müllerian inhibitory hormone. A final clinical situation where temperature effects on the testes are important is in varicoceles. A varicocele is a dilatation of veins in the scrotum. Specifically, it's a dilatation of the pampiniform plexus of the spermatic veins. If you look at this picture on the screen, you can see that the veins in the scrotum form this web of structures here. That's called the pampiniform plexus, and if a portion of that becomes dilated, that is called a varicocele. Varicoceles occur when there is some obstruction to outflow of venous blood from the scrotum, and you should know that they are more common on the left. The reason for this is a very high-yield tie-in with anatomy that you should know for step 1 of your boards. So the left spermatic vein drains into the left renal vein, which then has to cross the midline to reach the IVC. So there's a long course that venous blood has to travel when exiting the left side of the scrotum. In particular, the left renal vein can be compressed between the aorta and the superior mesenteric artery. This is called the nutcracker effect, and this can lead to high pressure behind the obstruction, and that sets the left side up for development of a varicocele. On the right side, in contrast, venous blood drains directly into the IVC, and there is no nutcracker effect. Therefore, right-sided varicoceles are much less common. And then another high-yield thing to know about varicoceles is that they're associated with renal cell carcinoma, which can invade the renal vein and obstruct the outflow of venous blood. In particular, right-sided varicoceles are so uncommon that when they occur, one of the things you have to consider is that there may be a renal cell carcinoma present. The symptoms of a varicocele include scrotal pain and swelling. Men sometimes describe a feeling like there's a bag of worms in their scrotum. If you look at the top of the screen here, there's swelling on the left side of this man's scrotum. That's typical for a varicocele. There is more swelling if the man valsalvas or stands. Both of these maneuvers decrease the blood flow from the scrotum and can increase the size of the varicocele. The diagnosis is often made by ultrasound. If you look at the bottom of the screen, there are these large black circles inside the scrotum here. I'm circling several of them with my pen. Those are swollen veins typical of a varicocele. And in addition to the pain and swelling, varicoceles can be a problem because they can cause infertility, both from the higher temperature. All that blood in the scrotum raises the temperature in the scrotum, and this can lead to poor spermatogenesis, and there is also poor blood flow. And for this reason, when men are being worked up for low sperm counts and infertility, an ultrasound of the scrotum is often done to see if there might be an occult varicocele. There are two treatments for a varicocele. The first one is a surgery. It's called a varicocelectomy. The surgeon isolates the dilated and abnormal veins and redirects blood flow through the normal structures. The second treatment is an embolization. This is performed by an interventional radiologist. A catheter is inserted into the dilated or abnormal veins, and then a coil or sclerosants are used to clot off those dilated veins and leave the normal ones behind. And that concludes our module on the male reproductive hormones.